Thank you, Janisha. Thank you for catching that. That would have been a bummer.
Of course.
All right. So this is the Journey Through Madness workshop. This is day one. A little bit about me. My name is Tim Dreby. I hold a California license in a private practice focusing on the treatment of psychosis, trauma, and neurodivergence. I hold a staff position at Highland Hospital Outpatient Psychiatric in Oakland, California, where I've worked for 20 years. I'm the award-winning author of Fighting for Freedom in America, Memoir of a Schizophrenia, quote unquote, and Mainstream Cultural Delusions. I've run survivor-led clinical groups exploring the contents of psychosis since 2008. At times I've done this up to 3 groups per week. So that's where I get most of my information from for its experience running the groups, where I get a lot of this. I'm the author of the Journey Through Psychosis workshop, and currently I'm planning to record 8-hour training sessions. And I'm a blogger on my website, www.timdreby.com. Also, I have a little elephant up there on the screen that I've done a lot of trainings in a lot of different places. Never really been picked up for a big venue. Got a 6-hour venue once, but part of the reason I'm doing it this way is that I do get a little bit of social anxiety, and I'm working on developing the training for something hopefully a little bit larger. So I really appreciate people for checking me out, and I'm really glad you're here. A little on housekeeping. I sent out some worksheets. You can put comments on the worksheets or the chat. Either one will work. We'll address questions and comments during reflection slides and during discussions during our exercises. There will be fewer exercises tonight. There'll be a few discussions, but as the training gets started, there'll be a number of exercises, and I'm not sure how long they'll last depending on the participation. So some of what I'm working on is getting the timing right. So I asked for people to please silence their cell phones, and feel free to excuse yourself if you need to use the restroom. We won't break for the 2 hours except to reflect and discuss. During the exercises and discussions, we may turn off slides and look at each other on Zoom. Since we have a small group, you don't have to turn on your camera if you don't feel comfortable, but would love to hear what you have to say. And use the worksheets I've sent to keep you focused or jot down notes. That's recommended. Probably today you can operate without the worksheets. There's less information but starting next weekend, the worksheets will make a big difference, and I really encourage you to print them up. They should have, it depends on when you printed them up, whether they have numbers on them. So that's a little detail. Maybe if you don't have numbers on them and you printed them up, you might want to put them on at some point when you get a chance. So I wanted to start with a check-in, and I wanted to, so we all know each other. So I was wondering if we could go over our name, our pronouns. It's optional where you're from, what brought you to this training today. How do you identify a family member, a survivor, a provider? That's optional, of course. One thing you hope to walk away with today from the training, and anything else you want to let us know about. Just be nice to know who's in the room tonight. So I'm going to stop the share and see if anybody wants to share. Yeah.
Sure, I'll go first. Let me go to the slide.
Okay.
Hi, good evening, everyone. My name is Erica. Tim, you stopped the slide, so I can't remember all the questions, but
Oh
I'll still.
yeah. Name and pronouns if you want.
She,
What's that?
she, her.
She, her.
Mhm.
And then where you're from.
Oakland.
Let's see. What brings you here? What are you hoping to get from the training tonight?
Well, you're my clinical supervisor at Highland, so you let me know that you were going to do this. I would really like to know more about psychosis. I think that it is an understudied diagnosis, and I'm seeing more patients, especially like young patients, coming to the ED with visual hallucinations. So I'm just curious to know, and no one seems to really understand how to treat these patients with this disorder. So I'm very curious to know what has worked for you, what tools I can pick up, et cetera, et cetera. And a little bit about me. I'm a new social worker. I work at Highland Hospital as well as Kaiser. And yeah, I'm just happy to be here.
Great job, Erica. Thank you. That's beautiful.
Can
Great
I pass it
introduction.
to someone, Tim?
Yes, let's do that.
Okay. I see Karen clearly, so I'll pass it to Karen.
Cool.
Thanks, Erica. I also don't see the slides up that show the questions that you had.
Here, I can
wrote
put it
down.
back up. I can put it back up.
Okay.
Um, yeah, they're just general.
Okay, so my name is Karen Mabry. My pronouns are she, her. I live in the Cherryland area, which is unincorporated, and it's Hayward, California. What brought me to this training today? I met up with you, Tim, at the, was it a workshop? Recently at the Senior Center in Berkeley, and got to reconnect after having worked with you very, very briefly at Highlands with the Best Now program. You were my supervisor at the time, and I really liked your perspective on psychosis. I liked hearing what you had to say, and so I am wanting to learn more about what your work is about and what you're doing currently. I identify as a peer, and one thing I hope to walk away with today is more connection, more knowledge, and that's what I have in mind.
Great. Thank you, Karen. That's a great introduction. Anybody, you want to pass it to anybody else? Let me stop the share.
Okay, I see you, Linda. How about you?
Okay, I'll go back to the Hi, Linda.
Hi. Okay, my name is Linda Jacobs. My pronouns are she, her. I'm from I live in Morgan Hill, and I came today to learn more. I've read your book, and I'm a family member of my niece who suffers from psychosis. And I'm a member of the Bay Area Hearing Voices Network, which I met you through, and I hope to walk away with more knowledge and ability to interact with my niece with grace and humility. And I also work at a crisis residential facility. I haven't worked there in a while. I'm on call. I used to work a lot. Since my surgery, I've taken a break. And I hope to learn more because a lot of the clients there are suffering from psychosis and I think that we need to learn a different way. I'm just not satisfied with the way what they provide. So I hope to learn a better way of doing it.
Cool. Thank you, Linda. And let's see. Do you want to pass it to somebody else?
I can't see anyone. I'm on my phone. I'm having.
Okay, so either Janisha or Andrew.
Let's do Janisha.
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 Okay. Janisha, here, I'll put the slide up. Are you there, Janisha?
Yes, I'm here.
Yeah.
Okay, well, my name is Janisha. I am from the Walnut Creek area. What brought me here today for the training? Oh, wow. Tim was, of course, my supervisor in the past. And he has given me such like great knowledge on psychosis and the different illnesses that diagnoses that patients that I would when I was working at Highland had, and it was very informational. I loved his techniques, loved his the tools that he used, the advice that he gave me. So I decided to that I wanted to take a deeper dive into the training. When he told me that he was putting together a training a year ago, and I'm just glad that it's finally in fruition and that is here, and I'm just excited to be here. How do you identify family members, survivors, providers? Oh, how do I identify? Okay. Yeah, and I've been seeing a lot of like now that I'm actually in the field. I'm also a social worker. I'm set to take my test to become licensed next month. So since I have been in the field, I have been seeing a lot I have been able to identify certain symptoms and things like that. So, and yeah, I'm able to kind of like Erica, and some of you that some of our providers have failed in regards with treating these patients. So wanting to know more information on how to treat these patients, the tools, techniques, and just overall knowledge of the training. So I'm excited to be here. Thank you so much.
Thanks, Janisha. Thank you, Janisha. That's great. And then Andrew, you want to check in a little bit?
Sure. Yeah. I'm on the East Coast, near DC. So, yeah, I'm lying in bed. I have my cameras off. Long day. Yeah. So I developed like severe mental health issues, and for an extended period of time, for some years, and working on getting my affairs back into order now. And I don't understand like a lot of how to frame, like my mental health condition. So I have like legal issues, and I've been diagnosed with psychosis, not schizophrenia. And it was kind of in dispute, I think. It's not clear exactly what happened to me. And I want to understand psychosis better. I've been hospitalized for other reasons, not for psychosis. So if I had psychosis, it would benefit me legally for a number of different reasons. I could show that I was mentally incapacitated. And now it's kind of, I don't know, like there's not a lot of people you can talk to about it. And yeah, so I'd like to learn more about psychosis in general and the symptoms, I guess.
Great. Thank you, Andrew. That's awesome. Thank you, everybody, for checking in. So I'm going to move on with the Next slide. And we'll see each other back in a few minutes. Welcome to the program. A little on why we're here is because one of the main reasons I think we're here is because the prognosis for psychosis is widely misunderstood or thought to be permanent. And E. Fuller Torrey in Surviving Schizophrenia defines about what percentage of people have the problem. And he says that 25% fully recover and don't have a relapse and identify as having had a nervous breakdown, not as a schizophrenic. 25% are much improved and respond well to antipsychotics and are relatively independent. 25% are modestly improved but don't respond to antipsychotics and show a lot of negative symptoms. 15% are treatment resistant and will be in and out of the hospital for the rest of your life. And I like to point out that when I first developed these experiences and was in a crisis situation, this is what my therapist said would happen to me. I guess she was a little frustrated or felt exasperated, but she put me down in the 15% realm. And I think that happens a lot when providers talk to family members, is they tend to try to, get them to realize this is going to be a major ordeal, and they emphasize it negative outcomes. And unfortunately, that can have really bad results. And of course, 10% end up not surviving this. So that's a little on that. And then if you go through 30 years, you can see that there's more people are much improved and respond well to antipsychotics over 30 years. And there's still ends up being a very, a much lower amount of people don't do well as time goes on, but some still do, and some people die young. When I studied schizophrenia in college in an abnormal psychology book, which I still have it over there on the shelf, and I read it back in 1995. But this is what really stuck in my head when I started having these experiences, was that schizophrenia is a complex syndrome that inevitably has a devastating effect on the lives of the person affected or his or her family. This disorder can disrupt a person's perception of the world, the way he or she thinks, speaks, or moves, in almost every aspect of daily functioning. And despite important advances in treatment, for someone to make a complete recovery from schizophrenia is rare. Well, yeah, that is a little bit of a chilling comment, that for somebody to make a complete recovery is rare. And I also want to say that E. Fuller, who we looked at, had the statistics, also isn't real friendly to people who've recovered from schizophrenia. He says things like, they often think everybody can recover, and just because they could recover doesn't mean everybody can recover. And it's just, even though his statistics are more optimistic than this textbook, it's still problematic. And I'll leave it at that for now. Why this is important is because of what's happening out there. I have a picture of Oakland where I work, and I collected some statistics from Oakland in 2022. 25% of the homeless are mentally ill. 11% of it is due to substance abuse. 35% of the homeless are chronically homeless. And when you look at that, you can see that most people believe that the people that are homeless and chronic have mentally ill, quote unquote, or have substance abuse problems. But there's a huge number of unsheltered and sheltered people in Oakland at this time. 4,000, over 4,000, almost 5,000 people are homeless, and that's kind of striking. To compare to that, I look at the number of beds in Santa Rita, and that's 2,400, and that's for the county wide, and 20 to 25% have a serious mental illness in that setting. This is also important because alternatives to homelessness on Social Security are what we often think of, and that would be boarding care, home living, homeless shelters, SRO, single room occupancy residentials. These are what people can afford with their Social Security, and there's a lot of challenges in those living circumstances at times. Section 8 housing projects, you'll hear in my story a little bit that I was working in one, and there can be a lot of challenges to living in a Section 8 housing project. You have to be able to acculturate to a lot of situations, and that was something that really prompted my madness journey. Long-term care facilities and state mental hospitals. I spent 3 months in a state mental hospital after the Section 8 housing project. So those are my experiences in alternatives to homelessness. I had some money, so when I didn't have a place to stay, I usually stayed in a hotel. So it wasn't a motel; it wasn't so bad. But these are what people face, I think, when they have psychosis, and a lot of times, I just think of all the nights I was worried about ending up on the streets and had nightmares and stuff like that related. I think it affects people with these challenges a good deal. So what I'm going to cover today is a system of treatment that is based on a proposed definition of psychosis that might deepen the understanding of what is going on inside a sufferer's mind and highlight treatment strategies that can lead to recovery. What I'll cover tonight is the background. That's what we're going to be focusing on. And then next week we'll go over joining, then we'll go over flexing, then we'll go over behaving, and part 4 is thinking. Thinking, the main treatment modality for psychosis is cognitive behavioral therapy for psychosis, and that focuses on thinking. I tend to focus on the other things that aren't as focused on in PTS, in CBT for psychosis, which is how to really go down the rabbit hole, how to get in and get trusted so you can go down the rabbit hole, and a little bit of how to help somebody flex without using consensus reality and imposing that on people. That doesn't work as well. Reality testing rarely works, and we're going to look at other options. The 8-part definition of psychosis that I'm going to review is comprised of these words: special messages, sleuthing, divergent views. Some people that I've worked with have made fun of me and said divergent views, but that's been that's a good comment on these words, is that they're a little complicated. Theories / frameworks, tricksters, retaliation reactions, social sanctions, and stigma. I think a lot of what goes on in psychosis is not just what's going on inside somebody's head, but also how they're treated and how they act as a result of what's going on inside their head, and also the stigma that lingers and lasts for years afterwards, after coming out of a break. Solution constructs. I have a lot of long, complicated descriptors of what solution constructs are, but and there are 8 of them, just like there's 8 of the definition concepts. When we look at joining, we'll look at the name of the problem area, and then the name of a problem area, and then we'll look at a solution. So we're gonna be looking at a lot of solutions, and as we define parts of psychosis, it's clear the solutions that come up. There's clear direction for how to treat somebody based on these definitions. But all these definitions we need to spend some time with to define. Flexing looks like this. Behaving looks like this. It's a little bit shorter. And you can see there's 2 problem areas and 1 solution suggestion for behaving. Thinking is reverse. And when you put it all together, it looks like this. And what we really have is a narrative that we're going to follow, which delves into what psychosis is and what's going on internally, how people make meaning, how people get tricked. These are the areas of flexing, then the behaving and the thinking in the bottom. So that's a little bit what we're going to be looking at. I want to take a minute for my story, and I'm going to play this. Please let me know if you can't hear it. 27 years ago, when I started my career working with people who experience madness, the only training I had to develop interventions was the DSM definition of schizophrenia. It took me several years and a promotion to learn how the people I was working with were confined to warehouse living circumstances. When I was promoted to a case manager, I started to understand how bad this could be. A few years later, when I moved to Seattle, Washington, an opportunity opened up to take a job that no one else wanted, starting up services in a high-profile Section 8 Housing Authority project. I went against the grain to establish trust and promote safety. I did things like investigate a suspicious death by the newspaper, ignore the fact that the company representatives were present at events I attended in the community, use a concert ticket bribe from the company to invite 25 residents to an outing at a costly music festival, and openly challenge the fact that the police were currently targeted vulnerable individuals instead of the residents who were known to be dealing drugs. The result was that I started to feel threatened. One day after work, I stopped off at my psychiatrist appointment, and I was trying to explain to her the corruption at the housing authority. For years, my treatment had been telling me that I was paranoid, but in the place where I worked, it made sense to be paranoid. I recall looking into her glass eyes, and I was counting $20 bills I owed her that I was retrieving from out of my sock. Look, I told her, have you ever tried to explain to someone that you're not paranoid before? It isn't that easy. She started to laugh uncontrollably. Shortly thereafter, I stopped taking my medication I had been on for 7 years. I started to think people were putting on skits around me to teach me a lesson. Then I faced a threat from a close personal friend who I had known had nefarious ties, and I ran away to Canada. Within 5 short days, I was the ward of a state hospital in Montana. In the hospital, I was told by other patients that the mafia was following me. I ran tests and learned that when people said they worked for the Mexican mafia, they weren't lying. I would be propositioned to join gangs that would protect me. And 2 months into my treatment, after my doctor had transferred me to the chronic unit, she would finally respond to my request to see me and say, You know, one time, Tim, we had someone come here who said the FBI was following him, and he was right. After 3 months, I was streeted. I took a Greyhound bus to Fresno, California, and managed to find a job and get an apartment. But when I ran out of meds, and I lost the job and could not find another one as my funds were depleting. Finally, my family intervened, and an aunt who lived in Piedmont, California, got me a job at an upscale Italian deli in an affluent suburb. I moved to Antioch, California, without a car and biked and used Bay Area rapid transit 2 hours each way to work at an Italian deli for $9 an hour. I could not get hired elsewhere and had concluded my family was a mafia family. It took me 10 months and a return to taking medicine before I could get hired in a social service agency again. Every day I traveled to the deli, I believed I was being followed. I just want to thank people for hearing my story. It matters a lot to me when people listen, and thank you. Moving on to the next slide. The story of the Special Messages Group starts in Highland Hospital, and this is a picture of Highland in Oakland, California. And you can see that the new hospital is up on the hill here, and the historical section is down the hill, and we're located over here on the second floor. We have a wing. It's been the corridor I've been on for 20 years, and there's bubble windows on the inside of the this area here, so that you can't look in. That are remnants of the old. It used to be the psych ward back some years ago. So I was hired to do therapy for psychosis. I knew what psychosis was. I'd experienced psychosis, but I was very worried about keeping my job. And I want to do a little depiction of what groups were like in the psychiatric ward. Approximately 30 participants are brought in by vans from their boarding care homes. 10 are to join room 2, the low functioning room. The first time I enter the room, I hear one of the participants scream, "Buzzards!" I scratch my head and make my way over to the whiteboard and start to describe what a symptom is. It takes me a few tries before I realize the participant screaming "buzzard" is actually talking about me. I start to appreciate his intellect. In time, some days later, when he has adjusted to me, he tells me he's an aristocrat with no teeth. Ha! His understanding is complicated and rich, and I'm sure to quote him in the newspaper. One of my favorite quotes that I remember him saying was, "Some days I feel somewhere between a human being and a giblet." Sometimes he would scream "vermin" very suddenly. As I educated people about what symptoms are, or what assertiveness was, or anger management means, I kept challenging myself. How am I really supposed to help these aristocrats? I slowly get to know others in the group as I get to know the man who screamed "buzzards." And that was really the important work that I was doing in the group, I think, was getting to know people. I'm careful to write good notes that focus on things like symptoms, anger management, and assertiveness. So coining the special messages concept, 6 years in, I complete my hours, pass those blood-sucking tests. I know Janisha can appreciate that right now, and obtain my license without revealing my history to any of my supervisors. I decide to try to get a group that explores what psychosis is via setting up a curriculum. I complete a rap training and practice using my story in that context. I disclose my own experience with psychosis and find it inspires the participants to do a lot of processing about their stories. I revise 8 topics and deconstruct what psychosis is and redefine it in ways that encourages participants to tell their stories. I create language to describe psychosis based on these experiences. These are the words that I've gone over that are a little bit long, a little bit nerdy, a little bit expressive. So at some point, I remember when I was using some of the words, I just came up with the idea that we were talking about goonie goo goo jive. And if anybody's ever seen Eddie Murphy's comic about his auntie who falls down the stairs and speaks her own language, and his drunken father makes fun of her and is very mean to her. Um, I think he's kind of talking about the P word or the psychosis word, goony goo goo language. And so I call it goody goo goo jive, just to try to lighten up a little bit. I didn't mean to start that. The structure of the curriculum, each topic was discussed in 2-hour sessions. Feedback and mutual learning sharpened the details associated with what psychosis was and how it worked. 8 topics were suggested of what needed to happen to cope and be successful in spite of psychosis. I think my vision for the group was that believe the way psychosis is defined and shut down in treatment reinforces patterns of social isolation across diagnostic and cultural divides. And I wanted to see if a new definition of psychosis, one that explored the experience, could bring people together into a subculture. The group was really popular, thank goodness. At times, the sunroom would be crowded with you know, a large portion of the participants in the program. And I think some of the things that made it popular were that I came out with my own history of psychiatric history, and that was the first time that I'd been quiet about it for 6 years, and then I came out. I was unsure about what I was doing. And I think when you take risks and you try to be authentic, that it really helps. I was open to suggestions. I wrote personal feedback into the next curriculum that they could then read and see that I was listening to them and changing things according to what they were saying. The group ran in cycles with a beginning and an end. I offered food celebrations at the end of each cycle. And I think the most important thing was that there was a spirit of risk sharing. I was taking a risk coming out with my own psychiatric history. And I think the client, I had the feeling that the clients really had my back. I think they liked the group, and they also were making sure that it was okay in the program. And when there's a spirit of risk taking, people take more responsibility because they want to be able to do what they're doing, and they're less likely to be disruptive or cause challenges. And I think that really helped, that we had a secure community, and then we had you know, people who appreciated that I was taking a risk. So my promise in this training is that if you learn the 8-part definition of psychosis and the solution constructs thoroughly, you'll be prepared to go down the rabbit hole with a roadmap. And I'm sure right now there's no way that you can remember all those words I put up there on the screen, but maybe by the end, when we've discussed them fully and described them, you'll be able to remember them, and you'll be able to use them as a system that supports you so that you can feel comfortable going down the rabbit hole. You'll know what to do when you get there, and how and what strategies you can use so you don't have to be scared about what's down lurking in the hole. So I want to take a minute and see if there are any reflections on the material up to this point. Does anybody have any questions or comments or thoughts?
Well, this is Linda. I must say that I'm excited to participate in this. This is something like I've always wanted with my niece. So thanks.
Thank you, Linda. Yeah, thanks for commenting. Yeah. Anybody else want to have anything they want to comment on? Thoughts?
Yeah.
Yeah, Karen.
I haven't seen this type of material or anything like it anywhere else. I mean, I'm hearing that you created it, but I want to really say that when you presented it to our Best Now class, I got a lot out of it. I felt a sense of connection. I felt like somebody understood a part of my journey and a part of the struggle and had some solutions. So I really connect to the definition you've created.
Thanks, Karen. Thanks for being here. I really appreciate it. Yeah. Okay.
Yeah, I have a question, Tim,
Yeah.
because I saw like a lot of the stats that you put up about schizophrenia. Are there a lot of comparisons between schizophrenia and psychosis? Are they relatable disorders? Is it easy to get them confused in terms of receiving the diagnoses? Like what, because I saw just a lot of the schizophrenia, so I'm just wondering
Yeah.
how that correlates to psychosis.
Yeah. Well, schizophrenia is the main psychotic disorder that people think of, and it's the first turn. It's the first turn to. That's what I was diagnosed with first when they could tell that something was a little bit off. And you know, I didn't seem to be being followed, so they didn't think I was really being followed. But there's a lot of different diagnoses with psychosis as part of it, and that's something we're going to look at in a minute. There's a total of over 30 different types of diagnoses you get in the DSM-5 with psychosis in it. And they're often thought to be different experiences. But if we look at what draws people together, and I'll say more on this in a little bit, but if we look at what draws people, if we look at it in a way that can draw people together instead of separate them, we can really do something to create a subculture instead of create a disconnect, a sense of disconnect and a sense of division. And I think in the Mad Pride movement, there's a lot of division, and I'm going to say something on that in a few minutes too. So, yeah. Thank you, Erica. Any other questions or comments? So I'm going to move back to the next section. We have we're doing good with time. So the background that we're going to finish up today, I want to talk about how what I think I'm doing is capitalizing on a new trend of counseling theory movements. I want to look at specifically what the medical model definition says, and we'll be looking at the definition of schizophrenia for that. And we're going to look at we're going to consider together what the solutions that come up from that definition are. Then we're going to look at the mainstream treatment and how it focuses on suppression and leads to a lot of stereotypes. And we're going to talk about what Erica was bringing up about treating psychosis across diagnostic divides instead of separately and individually as different types of diseases. We're going to identify psychosis as a culture instead of a label. And we're going to look at how new neurobiology understandings and new treatment against neo-Kraplinian views. the new treatment and the new neurobiology really support a lot of what I'm saying, I think. And then we're gonna end with a exercise, and hopefully we'll have time to do that tonight. So capitalizing on a new trend in counseling theory, I believe that there's a tendency to focus on the problems that exist out there and to create counseling theory that's based on addressing those problems. So if you look at addiction, you can look at AA and you can look at motivational interviewing. Motivational interviewing is a big solution that fits in, that helps bring people over to AA and connects, and it's a full-on psychology theory, you know. Personality disorders, DBT, dialectical behavioral therapy, and ACT, acceptance and commitment therapy. Those both address personality disorders. I really think that CPTSD also addresses personality disorders. I think there's a lot to be said that personality disorders are I don't like the way that tends to feel like you're blaming the victim with that diagnosis. But anyway, at least they've created a couple of theories that help the public understand what a personality disorder is. Because for years we were running around not understanding. And I was first diagnosed with schizotypal personality disorder, and they told me, don't go read up on it. You're just going to get mad at us, you know. And that's exactly what happened when I read up on it. Is I got mad at them. So I guess they were right, but it wasn't really supporting me in understanding myself, you know. Then dissociative identity disorder, I think IFS is a really internal family systems, is a system of therapy that really is addressing that issue pretty well. And it also works for addiction issues and eating issues and other kinds of trauma associated problems. But it's and I'll say more about structural dissociation somewhere along the line later on today. PTSD, EMR and somatic therapy, depression, CBT. I always think of Albert Ellis trying to get his data on an Ivy League campus and needing to think about himself differently to do so. Of course, there's CBT for psychosis, but I think that we could do a little better in focusing on the problem and not just, you know, I think there's more resources there for dealing with the problem. CPTSD, there's this online model I found called RRP, Relationship Recovery Program. It kind of is a mixture of AA focus, how to address deep trauma. RAP, I think that addresses institutionalization. I guess I put, and there's other new examples of problem-specific trend. And I wanted to ask you guys if you can think of any other examples of problem-specific movements in psychotherapy that would be examples of this. Does anybody have any?
So I have a question.
Yeah.
So as I understand it, psychosis is like a mental health symptom. It's like a suicidal ideation or suicide attempts, right? That like all kinds of different, like you say, you know, it's most commonly associated with schizophrenia, but you know, it can be associated with like other mental health conditions or like no mental health condition or like diet, right? You know, like some cases like that. That's right. It's kind of like that's sort of an umbrella term to say people who are disconnected from reality and have certain symptoms. Did I get that right?
Oh yeah, that's exactly right. Yeah.
Okay.
Yeah. And yeah, but I think, yeah, that's right. We'll talk more about that. Any other? Okay, so I'm just going to move on. What I think the problem-specific trend that I'm suggesting for therapists does is it normalizes the problem. It helps clinicians better understand and relate to the problem. I think that can be very necessary, especially with psychosis. Requires them to learn something before they're granted inclusion. Like if you're running a group and you're the leader of the group, you know, it's you have all the power, but if there's a system of knowledge you have to know about to run the group, that means you have to do a little more work to be included, and helps helps teach the public what the problem is. I think that's really important, and it develops jargon and terms so that people can learn them and understand the problem at a deeper level. What it does for participants, the problem-specific trend is jargon teaches participants what they already know in ways that help them organize and better see their process. It also proves to the recipient that the provider has been there before and knows what they're talking about and can provide guidance. And finally, jargon creates the space for solutions that can help the recipient get something they want. And the main characteristics of the problem-specific trend is that I think it takes a complicated problem, it deconstructs it, and it reconstructs it in a way that's solvable. I also think that creating jargon gives the group permission to exist, because when people don't understand what the problem is, it's just confusing. I think it creates a sense of exclusion that motivates people to learn more about the social group, and it highlights the role of the problem in everyone's psychology. IFS is a great example of that, not everybody has dissociative identity disorder, but a lot of people can really relate to it, and it helps a lot of different people out to understand psychology in that way. And it's really taken off it's probably the biggest trend in counseling theory right now. I think this kind of way of thinking of things it's important to view people as being in continuums instead of you either have it or you don't. You're yes or no, but everybody's on a continuum, and some people are closer to the problem and some people are farther from the problem. And I particularly like that because as you're working on getting better, you move away from the problem, and the problem takes less of your life up. And then if you have a relapse, you move back towards the problem. But it works, I think thinking of things in continuums is really important. And so at this point, I want to move and talk about the medical model definition. Defining madness as a medical illness leads to a great deal of limited and unhelpful advice. That's what I'd like to suggest. The mainstream definition of psychosis is defined by observed behaviors. This is Emil Kraepelin. He wrote back in the late 1800s. You can see he didn't shave too well. I guess that wasn't as much of a focus back then, but it's an old concept that something is broken in the brain and it causes certain behaviors. And a lot of the DSM-5 is based on Kraepelinian ideas, and they're a lot of people would say they're out of date. So the symptoms of psychosis, the way that most people understand psychosis, yes, it's a break from reality, but people tend to go to this set of symptoms right away, which is the hallucinations. Reports of sounds, voices, visuals, tactile sensations, tastes, and olfactory sensations that other people do not experience. A lot of people who have psychic experiences, experience hallucinations, and there's a lot of different they say 10%, 1 out of every 10 people hears voices, whereas 1 out of every 100 people has schizophrenia. So hallucinations is a big, but a lot of people, the minute they hear hallucination, they jump onto the this person's psychotic boat. So when you understand hallucinations in this manner, do you have any ideas about how to help somebody when you understand that hallucinations often get treated based on this definition? Like, if this is all you have to go on, like, what would you say to somebody about how to help? Does anybody have any ideas?
Yeah, one thing when I first went into treatment, mm, I I one problem like I had was I had been through like a lot of really bizarre trauma, right? And if I told people about it, stuff that was like well documented, like in the news, I shared one of the stories with you, Tim, and people would automatically assume that that was psychosis, right? Um, so that was one difficult issue, right? And I was suffering from psychosis, but I just didn't want to be disrespected. I didn't want to be called psychotic. At first when I went to treatment, and I went to like many providers, and I got into all these arguments with them about it. Because I guess the other part was like I did not realize that I was suffering from psychosis because the paranoid delusion seemed real or at least reasonable, right? As far as I was concerned. And I met one therapist that was good for me to start off with. He told me this funny story and about how he had a client who was like the Sixth Sense, right? That movie,
Hmm.
where like like the movie where like the boy sees dead people, sees ghosts everywhere, right?
Right.
And he was telling me about this client, and he said, yeah, and she had a job and she seemed to do all right. So he didn't really get into it, right? He didn't really go and try to pathologize or really address the fact that the client had all these hallucinations and just work on getting along with other people, right? And you can come talk to me about it, right? But that that way, and I think that was helpful too to have fun. I guess have a relationship where I could talk to someone without being judged or without being diagnosed. I think because the other problem I found was that once I got that label, once the clinician had that idea that I was suffering from psychosis, they just ignored everything I said. Like the guy, the finger twirl, right? This guy's nuts. I'm not going to listen to a word he says, right? And then
Right.
once you get into that mode, then F him, like I'm not going to have a conversation with you if you're going to be disrespectful towards me because I know that I have a mental health condition. I may not be able to tell what's real, but some things are real because I have, news articles or whatever. So does that
Absolutely,
make sense?
absolutely, absolutely. That was a lot like what I went through. I totally agree with you. Um, and yeah, everybody would ask me, "Are you hearing voices?" I would say, "No, no, 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 no." And finally, when I got better, I started hearing some voices. So, but yeah, it was the way people would stop paying attention to anything I said and not believe anything I said was really kind of extraordinary. So I want to really validate you there. And I just wanted to suggest some of the limiting advice that people often get for hallucinations is stating that they're not real, um, punishing them people when they get the hallucinations so they won't listen to them, not creating a safe space to share their experiences, presuming that all hallucinations are negative or traumatic, because some of them can be positive. Um, Unhelpful questions or comments like, "Did you take your medication today?" That's my five favorite words. Did you take your medication? Did you take your medication? Just listen to the radio. Don't talk back to them because it will look funny. And assuming that limited interventions haven't been heard before and aren't traumatizing to hear again. So those were some of the unlimited helpful advice. I used to think, yeah, just don't pay attention to them when I read it in the DSM-5, and I had to work with people without, without anything else to tell them, because I didn't understand. I never got training.
Tim, can I add something
Mhm.
about what my experience is? Particularly when I'm practicing medical social work in the emergency department,
Mhm.
where it is a huge business to get patients out as fast as possible. And even if they are on a 5150, if they don't find any support, like an inpatient psychiatric unit, they will lift the 5150 and send them home. But what I really want to get to the point to you make about hallucinations and how folks are treated when they are experiencing problems and they do have maybe psychosis and schizophrenia in their psychiatric history. If they come in off the street reporting that they've smoked meth, weed, whatever, drank alcohol, they won't even be treated. They won't take that into consideration. A psychiatrist won't do an intake. They won't even see them. They've written it in their workflows to not support patients that have a diagnosis or schizophrenia, psychosis, and are actively using because
Yeah.
they say everything is drug induced, so they're not going to waste their time. So
Yep,
the
good
barrier
point.
that I see is that these patients are not being treated. You have to really advocate in my role as a social worker for them to go into detox just so that they can begin to get the mental health treatment that they need, and they're begging for it. A lot of them are talking about their experiences of being an inpatient and getting clean that way and also treating their mental health. And they're not honoring the fact that they don't have the medications to consistently, you know, hopefully be able to treat them, the ones that are prescribed. So they're using the street medications to self-medicate. It's just horrible. It's horrible. And nobody cares about if you are poor and unhoused and have these diagnoses and you're using substances. So it's this
Right.
huge gap of populations are not being served because their basic needs aren't being met and they're doing the best that they can with what they have. Not excusing the substance use because it's affecting their health, obviously, but these patients aren't being treated or seen or recognized or acknowledged at all.
Right. Thank you, Erica. So true. So true. It's just like what Andrew was saying. The minute you hear schizophrenia and substance abuse, then it's off the table. It's like we're not working with them. They just need to sober up, and they don't have any needs. Yeah, that's horrible. Yeah. Thank you. Anybody else?
Yeah, I'd like to share on that.
Yeah.
I think the one thing from my personal experience that I've encountered the most with a provider within that medical model is fear. And it feels like as I'm being approached by somebody who's uncomfortable, I feel more uncomfortable and I can sense it. And it's not uncommon in that kind of situation where the person's really strongly holding on to some medicine and the conversation goes more like this: you need medication. You need medication because there's something wrong with your brain and this medication is going to fix it. End of story. And there isn't any chance to dialogue. There isn't any opportunity to share about some other perspective. It's as if it's not allowed. It's as if there's no time for it, and it's undesirable. And it even has felt like it's disobedient, like you're doing something wrong to discuss a different opinion with the doctor, and that could even lead to an unsafe situation. It's like, hey, you know what? You need more medication because you aren't getting it. You're not understanding what I'm trying to tell you right now, so you're not very smart. And so because of that, I think you need even more medication. And it can just lead to that kind of train.
Yeah.
And I just have encountered people being so afraid of me. I really, really have at times when I've been in the hospital, and no way to fix it or change it. And their need was to heavily medicate me. That's the way they felt best suited the situation. And that's what led to me feeling most unsafe. So having these opportunities to be in these support groups, for example, what you've done at Highland, where people can get together and discuss some of this, has been really important from what I experienced with you at Highland.
Right on. Thank you. Wow. All right. Anybody else have any comments? Okay. So getting on to a second key clue that people often makes people think psychosis is delusions. And this is defined as an idiosyncratic belief or impression that is firmly maintained despite being contradicted by what is generally accepted as reality or rational. And they continue to believe this in spite of, quote, the preponderance of the evidence. So people come in and start talking about their apartments being broken into, and automatically people think delusions, but in some areas that is really very likely or possible to be happening. That's something that I firmly believe. And when you start to see that somebody has a delusion, like you guys have said, the listening just goes out the door. But if you find out somebody does have a delusion, what do you think you can do, or what do you think some of the unlimiting, the unhelpful or limiting advice might be?
I've got an idea on this one.
Yeah, go ahead.
So just going back to my lived experience on this, in sharing about any kind of symptoms around delusions, I've experienced practitioners talking about me in the third person and not recognizing me in the room anymore, and just saying she doesn't understand, she can't hear me, she doesn't know what's going on, it's a waste of time to have a conversation, and I'm right there. And so becoming more curious about my experience is helpful, and knowing I am in the room and knowing I can hear
Yeah.
is very important. I can definitely hear. Maybe the way I'm expressing myself and the way I'm thinking isn't matching up to the situation, but I can still understand that there's a person in the room. And so even in working with peers that have had some unusual ways of speaking and have connected in different ways, I listen more than talk, for example. Ask them what's going on, and I'm curious about it, and that seems more helpful than saying to somebody else in the room, she can't hear her, it's a waste of time.
Right. Yeah, it's just othering you to treat you like that. Yeah.
I can try to answer this.
Yeah.
Some of the ways that I do it, just because primarily in my work I do support patients who are a lot of the times actively are seeing having visual hallucinations or hearing different things and in the middle of group sessions. So I really try to normalize it. Like, hey, is there someone here with us right now? Or, and I know it sounds kind of weird because I don't want to also be disrespectful towards the situation, but I try to like acknowledge if there are other things that are happening, right, that I may not be aware of, and like normalizing it being okay in the space for us to have these discussions. And so basically trying to normalize it. And
Yeah,
it
normalizing it is really important. I think what I used to do was I used to try to separate, well, and I've heard this said by CBT for psychosis, separate yourself from their reality and disagree with it. Say that's not my reality. But my experience was when people did that with me, I immediately mistrusted them and thought they were against me, and part of the plan to take away my power and keep me in the hospital. So that made people out the door for me. I don't know about other people, but I think I used to think that maybe building trust so I could reality test them would be a good way to help. But what I found when I actually went through it was that when people built trust and then just reality tested, it didn't help me at all. It just pissed me off. So some of these things that here's one, making sure everybody that they trust are on the same page. Like, we need to get a system working around them. We all need to be on the same page. That is not a way. When you're going through it, you don't want people to be all on the same page. You want to know that people will treat you differently based on who they are, and not just that you're not just, that's a way of othering you, you know? So, yeah, assuring me that there's no real conspiracy going on, not helpful. And did you take your medication? Did you take your medications? Not helpful. Yeah. So, yeah, thanks. Just leading, the next one is, aspect is disorganized speech, frequent derailment or incoherence, word salad, tangential or circumspect speech. And what do you think you can do for somebody who's speaking that way? Anybody have any ideas?
I do, but I didn't want to jump in too quickly. I want to make sure somebody else, if they want to, has a chance to speak first.
Well, love to hear from you, Karen.
Okay. I like the idea of stepping away from speech when speech is a problem, and thinking of other ways of expression. I've worked with a few people where we got involved with some art instead of thinking only about communicating with lengthy sentences. And while doing the artwork, communicating with a few words here or there, and then getting back to a few more words and a few more words. And by the time we were done with the picture, more communication was taking place. And it helped much more than trying to figure it out, trying to be more specific about words, and getting super caught up in every single word in every sentence and trying to make it come together. It just it feels like it creates anxiety and stress to keep going in that direction.
Cool. That's great suggestions. Yeah. Go ahead.
Sorry,
Yeah, Erica.
I was just gonna immediately agree with Karen. Like, I try to implement as many, like, after a brief introduction of a topic, like activity and mantra coloring worksheets that I feel like are super therapeutic for a lot of patients, and even activity sheets, right? If we're um, having a group discussion, but like doing so individually, so people can have their own time to cognitively process what it is that um, we're discussing, and then we come back and share in that space. I do think interactive activities, art, and just different expressions of um, ideas happen that are really therapeutic and help with the self-expression.
That's great. Yeah, great solutions. Yeah, I think one of the things I used to do would be to and I've seen this happen in John George too when I've been there, is I'd shut somebody down because they weren't making sense, and I'd stop them. And and I think that's exactly the wrong thing to do. If you're struggling to put words and get words out there, and you get shut down and you're silenced, it takes away that trust, and it makes it harder to even express yourself. When you have a feeling of trust, like you guys are talking about nurturing, it makes it much easier to express yourself, and that you have hope that they can express themselves. So yeah, I like what you're saying. Yeah. Um all right. Then there's all the negative symptoms of schizophrenia, and I put a list of them down there, like 11 different types. A lot of them start with A, and they're nice words like allogia and amotivation, avolition, and anhedonia. They're nice fancy words. So I thought that was like cool. But again, I just don't know, when you know somebody's struggling with this, what does it tell you as far as what you can do to help them? I don't think it really does a good job when you hear about negative symptoms of knowing how to work with them. That's just my impression. And I think a lot of these happen because of oppression or depression, but just feeling overwhelmed. But and some of them are parts of other problems, like attention problems can be parts of other, ADD or something like that. Flat affect doesn't have to be, a negative symptom of schizophrenia or of the psychosis, Anyway, I want to move on to talking about mainstream treatment at this point. How does our system address issues of psychosis? I think the medical model teaches symptom suppression through things like stigmatic social interactions, involuntary incarceration, recidivism. I said it. And involuntary medication. We're taught that we have to hold down these experiences and not show them on the surface. And I think suppression is an ethos of our culture that often gets internalized. So people feel like they can't show any signs of hearing voices or show any signs of these experiences, otherwise they're going to get totally judged. And I think the main way that the main way that suppression gets reinforced is through 5150s in California, being hospitalized. Outside of this, treatment can be very hard to find. Many refuse therapy or other alternatives because they don't like the experience in the hospitals. Many professionals argue that therapy doesn't work with psychosis. I've heard that many times over the years. And finally, therapists in training, when I was getting my licensing hours, they're routinely told to say psychosis is outside their scope of practice and utilize the hospital system for support. If you don't know what you're doing, don't deal with it. Instead of training somebody how to deal with this problem, the thing is to refer them to the hospital. And that's just really an unfortunate reality, in my opinion. So I want to take a minute and see what you think about the 5150 process, and if it teaches suppression, in your opinion, teaches people that they can't talk about these experiences publicly.
Yeah, I'll just share that in terms of the Bay Area, Alameda County is the highest county for utilizing 5150s. Like, our numbers are outrageous. I don't have the stats in front of me, but out of all the Bay Area counties, we issue the most 5150s. So for me, that's absolute suppression. And adding to the stigma and the underutilization of statistics for folks that this is actually really affecting, right? People aren't being honest coming forward because, like you said, it's so much stigma, and who wants to be placed on a 5150, right? And have that record and then endure that kind of treatment. So, yeah.
Right. And some counties have different systems, but the experience at John George is pretty extreme. They had somebody go in there with a camera, and they put it on the news, and everybody was up in arms, and they totally took down the staff, you know. But what happens on the 5150 is just there's this, you learn that you can't win, so you better calm down. You know, it's a real if you fight back, you're going to be they're going to get the best of you. So there's no use fighting.
Yeah, and you got two options most of the time: treatment, 5150, or jail.
Mm-hmm. Yeah. And some people do choose jail. Some people would
Yeah, I've
rather
seen
be
it
in
happen.
jail.
I've seen it happen. Yeah.
Yeah. Some people do choose jail for John George. Alameda County is really, yeah, it's a real hard place. Yeah. So I also want to point out the power of a word or a stereotype. And when people think about schizophrenia, or they think about 5150, or they think about delusions, they automatically go to these kinds of thoughts, like homelessness, mental hospitals, boarding care, living in a back room, day programs, poverty. And when somebody is told they're going to be in and out of the hospital the rest of their life and subjected to all these things, and we envision it, it's scary, you know. And it can take a very long time to get into a better situation. And then they have this definition of, I can't even say it, anosognosia. But it's this idea that the brain, the parental lobe gets broken. There's a lesion in the frontotemporal parietal area, in the right hemisphere of the brain, and that people, for some reason, when they have schizophrenia or Stockholm syndrome or PTSD, bipolar disorder, they cannot, cognitively, they're not aware that they have this problem. And it goes back to 1914, this word. But I like to think that a lot of times it's the stereotypes and the fears of what might be behind the stereotype that causes people to deny that what's happening to them is schizophrenia. You know, they don't want to be treated like that. So when we suppress these symptoms, there's negative consequences that happen mentally to the people experiencing the symptoms. We don't accept what is happening to us. We may judge ourselves and our experiences more and lack mindfulness. We may deepen our reactivity against or for the messages. We may react more. We may, if we don't focus on self-soothing or healing activities, and we may internalize the stigma and curse the medical model definitions. So by the time I get to see people in outpatient treatment, it takes me a long time to convince people that it's safe to talk about these experiences with me. Even if I'm talking about them, people don't believe it's safe. So I wanted to see if anybody had any reflections or thoughts about that part or what I just reviewed. Any thoughts?
Well
Yeah,
said.
oh, sorry.
That's okay. That's my comment. Well said.
You agree? Yeah. Okay. Yeah. Thanks. All right. I'm gonna try to go through this a little bit quickly. Treating psychosis across diagnostic divides. The idea that we can do this without all these labels. These are all the labels. These are the 20 labels. And then there's 10 different types of psychotic disorders that are substance abuse, because there's 10 different types of substances in the DSM-5. And then if you have a medical condition, any medical condition can cause psychosis, so that you add a whole bunch of them to this too. So there's just this enormous list. I also add dissociative identity disorder in there, because what I've found is that when you start talking about voices, that you find that a lot of the voices will come and take over the body, and then they'll forget what happens when the voice takes over, and they get to know the voice and they're afraid of the voice. And so people get diagnosed with schizophrenia when it's really dissociative identity disorder. That happens a lot. And there's a lot of crossover, because if you think you're being followed, you may have dissociative episodes, and it may be very traumatic, and you may develop dissociative parts. So they go hand in hand, and they're often thought to be very separate. But if you look at them together, there's a lot that can be learned about what you can do with these situations. Special messages acknowledges that there may be negative effects from dividing people up by labels instead of unifying them and letting them explore what they have in common with each other. There's a lot of negative effects of differentiation. For example, there's no support system for voices or delusions like there is for AA, like there is for substance abuse. There is the Hearing Voices Network, and we'll be talking about that, but historically it hasn't been strong. In many clinical settings, special message realities may be expected to be concealed. The poor prognosis statistics remain and can become self-fulfilling. And I like to suggest this, that there's professional flight away from the SMI population. I think for a while people often come and work with the SMI population, and then they get their license and they move on, and they work with other people, and there's not this sense of I'm going to stay with these people and I'm going to really figure out how to help them. And you do get people who are like that, but it's not always. A lot of times you just get people who are learning and then they move on, and that's kind of a challenge. Not a lot of treatment specialization for psychosis, and the culture remains divided in many ways. And I think that's the biggest problem with this differentiation problem, is that the culture remains divided. I put a slide up here about divisions in MAD culture, and one of the, there can be a lot of infighting experience with people who are in the MAD pride movement. In my experience, I've had a lot of there's rejection of psychiatry, there's rejection of medications, there's people who are saying you're not recovered if you're not on medications, if you're on medications. There's rejection of the hospital, there's rejection of therapy, there's even rejection of peer support sometimes, I've found. And there's different attitudes towards medical model, towards NAMI, and family support. Some people are living at home and some people are in warehousing conditions, and that divides people. If you're divided between the schizophrenics are over here and the bipolars are over here, and you see the bipolars getting better treatment, it divides people against each other. Differing attitudes towards poverty divides people. Mood challenges and social skill development. Some people are more blessed with social skills, and some people are less blessed with social skills. Causes a lot of rifts, and I think there's a lot of underlying realities that we have to look at that's behind the divisions in MAD culture. Things like racial, gender, sexuality differences, need to work, need to care for children, educational prestige history, differing aptitudes, history of abuse, including emotional and material neglect, and substance abuse. Substance abuse is a big divider. Like, are you open to self-medicating, or are you not open to self-medicating? Yeah, people get very you can make more money if you're in substance abuse than you can if you're if you're disabled with mental health challenges sometimes. So yeah, a lot of divisions. Differentiating diagnostic categories and support help explain these divisions. Sometimes treatment providers don't realize the need to challenge message receivers to realize that they have things in common with one another. But that is really important. When I was in treatment, I was always like, I don't hear voices. I don't want to be equated with other people who hear voices. And that was really unfortunate for me that I took that attitude. I probably needed some help with that. Listening to the experience of others. I just put this slide in there. You realize you're not alone. You find people who have true compassion and not sympathy for your suffering. You get motivated to change your perspective, particularly when you relate yet realize others understand their experiences in different manners. So I'll say that one more time. You get motivated to change your perspective, particularly when you relate yet realize others understand their experience in different manners. That's really important. You learn about other ways to explain these experiences. When we can see how others get stuck in their specific situation, we get insight into how rigid views on our own messages keep us stuck. So I want to see if anybody has any thoughts about this material. We're rolling in on the second hour. Any thoughts?
I'd like to say something about this division
Mm-hmm.
that I've noticed in the crisis residential that I work at, that there are, staff who prefer certain clients versus other clients. And I've seen many times where they don't necessarily speak in a respectful manner when sharing about what's going on in the day and stuff, and they kind of brush off or don't even put in the effort with those who are having a lot of psychotic episodes. So I do see that as an issue, and I can understand how it divides everyone, and it is harder to bring people together because there's a lot of people who can take advantage of the benefits they get from
Yes.
more attention and stuff. So yeah,
Yeah.
it's definitely an issue.
Good point. Very good point. Thank you, Linda.
Mm-hmm.
Any other thoughts?
Yeah, I don't necessarily see like it may not necessarily be a good idea to bring everyone together. Like I think one thing that, I found is that I was more prestigious, like I managed my own nonprofit when I was younger. Then I got a law degree, and then I developed, psychosis or something like that. Just something happened, right? And it derailed my career. And then I went through treatment, treatment programs, day programs, right? And I found that there's definitely that not necessarily the people in this room, but among many of the government providers, there's this tendency to to do everything like let's treat everyone at a third grade level, right? Do all the programming at a third grade level, and then treat everyone the same, right? And then especially, that we're involving people with, intellectual disabilities. And it's almost like it's easier, right? There'll be like a minority of people with intellectual disabilities, but group everyone together and then have like that programming, which is bad. Yeah, people need to be treated as individuals.
Yeah,
And
that's a good
and
point.
especially too that there's that emphasis that people with severe mental illness can't be educated, right? They have to be treated like children, and they because if everyone's going to be grouped together, the lowest common denominator will win, right? That will be the standard, and it's not fair to people who have more prestige, higher education, and it's not fair to people with lower education either, because it does have that very strong infantilizing and degrading effect, I think. The other thing that kind of I thought with medication, mm, I've been diagnosed with severe mental illness like PTSD and psychosis, depression, and then with stimulant abuse, that I abused lawful stimulants over a long period of time, right? And so for me, like it wasn't so much that I needed, and I think that again, there's that one size fits all model that with maybe government providers that have a lot of people, right? Then instead of addressing people as individuals, they say, well, let's put everyone who shows psychotic symptoms on antipsychotic medications, right? And it's not right. I think that for me, like I attributed developing psychosis, if that's what I experienced, was to be trauma, at long periods of isolation, right? Like years of not talking to other people, and then chemical dependency issues, right? So resocialization and sobriety, right? And therapy, right? That was kind of like what I needed to do to get out of it, right? And there's a lot of different explanations as to why people may not need medications. And I started speaking on it, like going and speaking, saying like, yeah, like I survived psychosis. And Someone asked me that, like, how about medications? And I take Wellbutrin now, but I don't take antipsychotic medications because I needed to stop, like, dealing with certain people and situations in my life that were very, very stressful and unmanageable situations. A lot of that, a lot of lifestyle, relationship changes, healthier lifestyle, not using stimulants, right? All that stuff, but not antipsychotic medication. Um, so I think that's because if people have those other factors, right? Like, I don't know. I'm a huge fan of The Walking Dead, and they had a lot of great like examples of people that develop psychosis due to isolation, right? Or trauma. And it's very realistic. I mean, there's not real people on the show or real case studies, but you see how people, different situations over time, conditioning, psychological conditioning can lead to psychosis over periods of time, right? And that stuff can't really be addressed I'm not saying it can't be, but medication's not really may not be the right way to go. So,
Absolutely. Yeah. I agree with you about everybody needs to be seen as an individual. Um, I guess what I found is that um, when when I've learned to listen to people's stories of psychosis and relate to them, that it's helped me like when somebody hears voices and I've started to consider myself as maybe having heard voices at times, it's helped me decrease the amount of distress that I felt when I wasn't thinking it was possible that I had been hearing voices. Um, one of the things, an example is, I was not into aliens. I was in the mafias. But when somebody one time defined my experience of being, being met by a crew of policemen by saying they thought they were aliens, it relieved me instead of because I was open to what they had to say and I wanted to collaborate with them. And if they were aliens, it wasn't it's distressing that the police were against me for, and put me in the hospital and continue to suppress me over and over again. Um, it was much more comfortable for me to think they were aliens. So I opened my mind and I became less judgmental of the people around me. And I feel that I have become more culturally fluid and able to work with people in different situations um, by listening to people's stories. And I think it's been a good thing for me. And that's really what I mean. Yeah. Um, and I've seen a lot of people really become very open and get a lot of support that way. And I really admire people who can do that, you know. So but
I-
by no means am I saying that everybody should be treated the same way and that everybody should be put on medication. Some people don't need the medications and they're not very good for you.
and I'm not saying you did. The other thing I thought, like, breath work was very helpful also. Like, not being able to talk was something that someone else brought up here. And doing, breathing exercises, kind of like breath work, I thought that was very helpful for me, to relieve stress. Or other stuff like body movement, stuff along those lines, that like talking wasn't effective. And then something I saw on your slides that was really interesting that you'll probably flesh out later was that there's definitely like a psychosocial kind of model to it, that I mean, for me, like I did have like an actual legal dispute with like organized crime, a cult, terrorist group, whatever you want to call it. And there were stories about it online, right? So that was a real traumatic incident. And then like people would see the stories because the first thing that you Google search when you saw my name were like these stories, right? So it almost put me into another reality because everywhere I'd go, you'd have to deal with this not to say that I'm like Casey Anthony, not like that, but kind of, it puts you into that, you have to deal with everything differently. And it wreaks havoc on your social life. It causes you to be paranoid. And then all that negative stuff would get put onto me, right? Which did, and then when I moved down to Mississippi, it was like a nightmare, right? Having to, being publicly outed for something like that, and you couldn't escape it anywhere you went, right? And that was a huge mind F. And that caused me to develop psychosis, always being under that stress and, having people mess with you constantly. And there's something I read stories online about people who alleged, the targeted individuals movement,
Yeah,
gang
yeah,
stalking, and all that kind of stuff.
yeah.
And I think that's real, but one
Uh-huh.
thing I noticed about people who allege that, uh, I think that once you're out of it, like once you kind of detach, people who are, might be drug addicts, like hardcore drug addicts, or start developing the psychotic symptoms. And you go around and you act that way in society. Once you get into that state where you're paranoid and you've lost social skills and you don't know how to interact with people, you go around doing your thing and you act in a messed up way without realizing it. And people react harshly to you because you don't act right. And then you get the idea that people are always ganging up against you. And they are in a way, but there's a reason for that. It's not because there's a conspiracy, it's because you need to learn to, conform your behavior to social norms. And once you get out of whack, it's really hard to kind of get back into the social conventions and that kind of thing. And I think that's huge when it comes to like understanding psychosis, because that plays a lot into it, not being able to grasp like how all of the normal social codes and how once you lose contact with other people. So
Yeah, yeah. Good point. So those are really good points. Yep. Anybody else
I'd
have
like
any?
to,
Yeah, go ahead.
one thing about some of these groups and even adding to what Andrew said is that um, in this feeling of support and in these groups, it can feel hard to improve at times. And I've seen this and I've experienced it because then you're going to lose that support group. It's like if you get better than everyone else, well, then you move on and you lose all those new friends and you lose all those people and all those ties and that identity that is required to become a part of that group. And once that is no longer a part of you, well, then who are you and what do you do? And it can feel very overwhelming to improve. And it can feel very hard to move forward and find that new group and to find those new connections when that's all there was. And even within the board and care, the desire to improve, is it always there? Well, then who are you when you move on? And then what do you do when there's these new responsibilities, when you haven't had the trust of somebody to actually feel like you can handle responsibility? And that aloneness, the isolation that can result from an improvement. That's what I wanted to add.
Great point. Great point. Yeah. Thank you. All right. Anybody else? Should we move on? It looks like we're about out of time. So I think this is where we'll stop for the evening. Thank you for those comments. They were really thought-provoking and very good points. Yeah. So checking out a little bit. Does anybody have any feedback for the night? Are you guys on board for next week to try to go into this a little bit further?
Definitely.
yes, thank you. Thank you for putting this on, Tim.
Yeah,
Yeah.
absolutely.
Great group. Thank you.
Okay. Sounds good. Well, I really appreciate everybody coming here and yeah, and really good comments, making me think a lot. We'll catch up with you next week.
All right, bye.
Bye. Have a good week.
Bye. Thanks.
Bye. Yep. Bye, Linda.